Can we? Mohan? Good afternoon, all. Welcome you all to the webinar 2 of this series. As I said earlier in the last week, we have had the season 1 and season 2 of webinars in 2020, 21, and 22. We had a live workshop on in regional anesthesia. 23, we are back with the webinar series. This series particularly we have focused on the critical care aspects of perioperative care, and we got inspired by the critical care clinics that was released just a couple of months back by Lee Fisher, the anesthesiology clinic, which was dedicated to critical care for the anesthesiologist. And the 16 topics which are there, we felt was a very comprehensive book on perioperative critical care. And I thought we can discuss the similar topics in the next 4 weeks. And we had webinar 1 in last Tuesday, and today we are having second of the series, and we are again privileged to have Dr. Jigishu Vasis Divatiya as one of the moderator for this session. He needs no introduction. His introduction is voluminous, but in brief, Dr. Divatiya is the current head and the Department of Anesthesia and Critical Care at Tata Memorial Hospital, Mumbai. He has been the past president of Indian Society of Critical Care Medicine India, and he is also the past editor-in-chief of Indian Journal of Anesthesia, which has achieved a very high impact factor during his regime, and it's continuing to achieve a high impact factor. And also, he is the president-elect of Indian Society of Anesthesiologists. So, welcome, Dr. Divatiya. It's our privilege to have you. With this, I would like to introduce my co-moderator, Dr. Kiran. He is in charge of our surgical intensive care unit. He did his master's from Usmania Medical College, and then subsequently he did his fellowship in critical care medicine from our hospital. He has been working with us more than a decade now. He also completed his EDIC 2 years back, and he heads the ICU in our hospital. Basically, he takes care of 58-bed surgical intensive care unit. As you know, AIG Hospital is a multi-specialty 1,000-bed hospital, and we take care of 14 OTs and 58-bed surgical intensive care unit. And on an average, we do almost about 1,100 procedures every month, a major chunk being surgical gastro and surgical onco. And we thought this was an apt series for us, not only for us, but also for our colleagues who are practicing high-risk anesthesia. So with this introduction, I hand over the proceedings to Dr. Kiran, my co-moderator. He'll introduce the speaker and the topics for the today's discussion. Before that, would like to hear a few comments from Dr. Divatiya, who is moderating. Thank you very much for giving time this afternoon, sir. I know you are a very, very busy schedule, and OT is still on. He may disappear anytime, but he'll be with us for giving his expert comments at the end. So, Dr. Divatiya, over to you, Dr. Divatiya. Can you just unmute yourself, sir?
Yeah. So thank you very much, Dr. Pandya. I think firstly for having me here, but I think especially you and your team need to be congratulated for starting this very nice series on perioperative care and intensive care. I think it is very relevant to the practice of anesthesiology, and you, of course, your team has a vast experience with major surgery and the care of such patients. And I mean, they will need care for their preoperative comorbidities, for problems that happen during the course of the procedure, and of course, for some postoperative complications. So I think the topics that you selected even today are extremely relevant and extremely important, and I'm sure they will benefit all your listeners and viewers. So thank you very much and wish you all the very best.
Thank you, sir. Dr. Kiran.
Good afternoon to one and all. Those who are watching this live webinar session, welcome to Perioperative Critical Care Web Series Part 2. Our critical care webinars are based on anesthesia clinic books which are published in March 2023. Basically, the clinical book is on current topics in critical care for the anesthesiologist. Today, we will be covering 4 interesting topics. First one is coagulopathy and emergent reversal of anticoagulation. Second one is recovery from anesthesia, the changing paradigm. Third one is the perioperative fluid therapy and volume assessment. The final one is on impact of perioperative nutrition on microbiome and patient outcomes. So the first topic, the coagulopathy and emergent reversal of anticoagulation by Dr. Manjusha. She did her MBBS and post-graduation from Andhra Medical College, and she's working as a consultant anesthesiologist at AIG Hospital. Over to Dr. Manjusha.
Have underlying coagulopathy. Evidence-based coagulopathy advances over the last decade in both anticoagulant like to discuss current coagulopathy potentially undertreated coagulopathy for the counter aspirin or aspirin lifestyle. A word about herbal products. Medicinal plant products have been used in healthcare since the time immemorial. During the past 3 decades, the use of herbal supplements have been on the rise. To name a few, aloe vera, cranberry, garlic, ginkgo, ginger, and all these things are having an effect on the clotting process. We need to take a proper history from the patients to manage coagulation and their reversals. Determine what doses of medications the patient is on and the last time the dose was taken. Why are the patients on anticoagulation? There are different medical conditions wherein patients are needing anticoagulation. For example, atrial fibrillation, history of deep vein thrombosis, pulmonary embolism, hypercoagulable states, left ventricular thrombus, and mechanical heart valves. Why do we need to reverse the anticoagulation? Being anesthesiologist, our concern is when the patient comes with anticoagulated or antiplatelet drugs for various medical prothrombotic states, we need to strategize when to stop or when and how to reverse the anticoagulation effects. This is the delicate art of balancing thrombosis and bleeding during emergent surgical procedures in the perioperative period. Coming to basics of coagulation cascade, as we all know, this includes intrinsic, extrinsic, and common pathways. The intrinsic pathway is having factor 2, factor 12, 11, 9, and 8, along with prekallikrein and high molecular weight kininogen. It is monitored by testing activated protamine time. Extrinsic pathway is having tissue factor and factor 7. It is monitored by PT and INR. Common pathway is having factors 10, 5, 2, and 1, which is monitored again by PT and INR. Coming to platelet function testing, platelet function has proven somewhat difficult to measure in a rapid, unstable fashion. It is very difficult to, bleeding time can be taken as a measure, but it is neither sensitive nor specific to evaluate platelet abnormalities. Platelet function analyzer, PFA 100 or PFA 200, which is also marginally more useful than the bleeding time. Platelet function analyzer is an automated analyzer found in many labs that attempts to create higher shear conditions that are expected to cause hemostasis. This test is also neither sensitive nor specific enough to preclude further platelet or von Willebrand factor testing, and should therefore likely not to be relied upon in any clinical important sense. A platelet count, if it is lower than 20,000, we consider the patient is definitely going to bleed. Even though patients are having more than 20,000 of count, patient can also bleed. So it is a very balancing decision that we need to take. Platelet count, whether it directly correlates with a bleeding tendency or not. Coming to viscoelastic testing, these are the bedside point of care assays that have increased in use due to their ease of interpretation and the fact that they provide real-time measurements of clot formation and integrity. Prominent commercially available tests include thromboelastography and rotational thromboelastometry. Here in AIG, we do thromboelastography as a routine basis. These tests are frequently faster to run than conventional coagulation tests. Coming to medication-induced anticoagulation and their reversing, the core of the topic. Warfarin, one of the most commonly used anticoagulants in our practice. It's a water-soluble vitamin K antagonist, which interferes with vitamin K-dependent clotting factors 2, 7, 9, and 10. This can be monitored by measuring PT, a test that is affected by reductions in factors 2, 7, and 10. Its reversal can be done by giving 5 to 10 milligrams of intravenous vitamin K infused over 30 minutes along with 4-factor PCC. 4-factor PCC is superior to FFP for rapid reversal. 4-factor PCC has got an extra of factor 7 compared to 3-factor PCC. A word about FFP. FFP is used for more coagulopathic volume resuscitation because in exsanguinated hemorrhagic patients, FFP will actually aid in filling the volume at the same time correcting the coagulopathies. FFP or PCC only work for 8 hours. By the time, vitamin K will work after 6 to 12 hours, so both must be given simultaneously to reverse the effect. Again, bleeding and thrombosis, we need to take a balanced decision. Depending on the INR management, in the elective cases, in the absence of bleeding or the planned procedure, we need to decide, depending on the INR, how we have to reverse the warfarin effect. If the INR is in between 3 to 5, simply hold the warfarin. If INR is in between 5 to 7.5, hold warfarin and along with 1 milligram of vitamin K per orally. And INR, if it is between 7.5 to 10, hold warfarin along with 2.5 milligrams of vitamin K per orally. If INR is more than 10, hold warfarin along with that 5 milligrams of vitamin per orally. Medication-induced coagulation. The next dose is heparin and low molecular weight heparins. Heparin remains one of the oldest anticoagulant medications discovered in 1916 that is still in use. It acts by activating antithrombin, which in turn inhibits thrombin and factor 10A. Heparinoids are the heparin analogs, whose action depends on the length of the saccharide chains. They also inhibit thrombin. Heparinoids acts upon the length of the saccharide chains, and this unfractionated heparins, low molecular weight heparins, and fondaparinux. Unfractionated heparin inhibits both thrombin and factor 10A. Low molecular weight heparins, as they are having shorter length of the chains, they can only inhibit factor 10A. Coming to monitoring, medication heparin unfractionated heparins can be measured in the lab by measuring APTT, which is a reliable test, antitenia activity, which is also a reliable test, which ACT, activated clotting time, which is also a reliable test to measure the anticoagulation effect of unfractionated heparins. Low molecular weight heparin activity can be measured by measuring antitenia activity, and fondaparinux is also having an antitenia activity raised, which is reliable test. None of these tests will be, none of these anticoagulants will be increasing INR except when unfractionated heparins are given in large doses. A word about heparin-induced thrombocytopenia. It is a potentially devastating immune-mediated adverse drug reaction caused by the emergence of antibodies that activate platelets in the presence of heparin. One of the abnormalities that may be caused by heparinoids overdosage. It is described in two types. Type 1 HIT, which is also called non-immune heparin-associated thrombocytopenia. It occurs within 48 to 72 hours after initiating the heparin therapy, and it gets reverted to baseline within 4 days once heparin is stopped. Thrombocytopenia is mild and transient here in this type, and thrombosis is also not there. The type 2 of heparin-induced thrombocytopenia is actually called immune-mediated thrombocytopenia, which is associated with risks of thrombosis and thrombocytopenia, which is more dangerous. Despite thrombocytopenia, bleeding is rare. Rather, it is strongly associated with thromboembolic complications. The formed complex along with heparin and platelet factor 4 complexes, which leads to platelet activation, which causes a procoagulant state. So there occurs thrombosis despite thrombocytopenia. Coming to reversal of unfractionated heparins. Protamine, it's a mixture of peptides originally isolated from salmon. Reversal of heparin anticoagulation is achieved with protamine. Protamine binds with heparin with very high affinity. The formed complex, the heparin-protamine complex, is less effective. Protamine is less effective at antagonizing anti-10A effect of heparinoids. Thus, it is an incomplete reversal agent for low molecular weight heparins and fondaparinux. We need to see for anaphylaxis reactions type 1 and type 2 while giving protamine infusions. Coming to the general rules of protamine dosage, usually we should avoid giving protamine more than 50 milligrams at once. It should be given very slowly, IV over 15 minutes. And the rapid administration causes hypotension, bradycardia, and anaphylactoid reaction. Coming to the protamine dosage as per the heparins, for every 100 units of heparin, if it is given in last 30 minutes, 1 milligram of protamine will reverse the heparin effect. For every 30 to 60 minutes, for every 100 units of heparin, 0.5 to 0.75 milligrams of protamine will act. As the duration of the heparin intake increases, the dosage of protamine decreases. Reversing medication-induced anticoagulation, reversing an enoxaparin effect. As told, if it is given less than, in the last 8 hours, for every 1 milligram of enoxaparin, 1 milligram of protamine will reverse. If it is given within 8 to 12 hours, 0.5 milligrams of protamine per 1 milligram of enoxaparin. Should say protamine will reverse enoxaparin by only 50%. Reversing the effects of dalteparin or tinzaparin, if it is given last 4 hours, 1 milligram of protamine and acts for 100 units of dalte or tinzaparin. It can be repeated, the half of this dose can be repeated after 4 hours. Coming to a monitoring of the reversal of unfractionated heparin effect. Monitor PTT in 10 minutes after giving protamine, and then again within 2 to 8 hours. And to measure the reversal effect of enoxaparin, monitor 10A levels after 2 hours of protamine given. Most of the times, 60 to 75% of enoxaparin gets neutralized. May consider redosing at 0.5 milligrams of protamine for 1 mg of enoxaparin. The maximum dose that we can go with is 25 milligrams of protamine at once. Coming to direct oral anticoagulants. Even though the vitamin K antagonists are the mainstay of treatment of venous thromboembolism, arrival of direct oral anticoagulant medications has added an alternative profile that addresses many of shortcomings of the VKs, that is vitamin K and antagonists. Direct oral anticoagulant agents they do have predictable pharmacokinetics and pharmacodynamics, which allows us for fixed dosing and rapid onset of anticoagulant effect. This also allows for less frequent lab monitoring. Despite these benefits, DOACs provide a challenge when coagulation tests are needed for assessment of coagulation states. As indicated, they act by either inhibiting thrombin or inhibiting factor 10A. The direct thrombin inhibitors, example is the dabigatran. The factor 10A inhibitors are rivaroxaban, apixaban, and edoxaban. As we told, the monitoring, despite these benefits, monitoring has been a challenge for us. Measuring APTT and PT, actually they are prolonged, but they are unpredictable tests. TCT is specific test for dabigatran. Antitenia assay is predictable test. The preferred test for assessing the anticoagulant activity of rivaroxaban, apixaban, etc. is a chromogenic antitenia assay that will correlate closely with plasma drug levels. But this test is not readily available in every hospital. Factor 10A inhibitors, rivaroxaban, apixaban, edoxaban, and fondaparinux. Its activity can be measured by usually measuring INR, but ideally by anti-10A levels. To reverse its effect, 4-factor PCC is considered. Oral intake of charcoal in a dose of 50 grams can be considered if it is taken within last 2 hours. Coming to briefing of pharmacology of direct thrombin inhibitors and factor 10A inhibitors. The dabigatran, which is a direct thrombin inhibitor, it can be measured by crude lab measurements measuring APTT, activated PTT. Preferred lab measurement is thrombin time, and its antidote is idarucimab. The rest of the medication, fondaparinux, rivaroxaban, apixaban, and edoxaban, can be measured by anti-10A level assays. This can be reverted by giving 4-factor PCC, possibly andexanet alpha if available for oral agents. A word about andexanet alpha, specifically designed to reverse 10A activity, 10A inhibitors. Clinical data available about this medication is limited, and it is very expensive drug. Many hospitals have not chosen to include this into their formularies. Apparently, andexanet alpha is considered to be costing around 50 lakhs for 1 dose. This table is showing the reversal of specific thrombin inhibitors and factor 10A inhibitors. Specific reversal agent for dabigatran is idarucimab, as we have already discussed. And for factor 10A inhibitors, it is an andexanet alpha. Both of them, they are costing insanely high. Prothrombin complex, which can be considered for both of them to reverse their effect. Other options include antifibrinolytics, activated charcoal, and hemodialysis. The same for the anti-10A inhibitors too. Coming to the antiplatelet medications. Encountering antiplated drugs in the operating room is quite common, secondary to an ever-aging patient population and the high incidence of cardiovascular diseases and subsequent interventions performed annually. Although the archetype of this drug is aspirin, many other classes of these drugs have arrived, which are having irreversible and reversible action. Aspirin acts as a COX inhibitor, which in turn inhibits thromboxane A2, which inhibits platelet aggregation. Clopidogrel is a P2Y2 inhibitor. Along with that, prasugrel and ticagrelor are considered to be in the same category. The process of the medication acts through these medications act through inhibition of ADP receptors via P2Y12 receptors on platelets. This is done irreversibly in case of clopidogrel and prasugrel. Again, management of patients who need emergent reversal is a balance of risk versus benefit based on the severity of hemorrhage as well as indication of antiplatelet therapy. The first step for any clinician facing this situation should be discontinuation of any antiplatelet medication. Thankfully, some of the medication in this category are reversible and are having relatively short half-life, such as cangrelor and tirofiban. These medications are often administered along with aspirin as a part of dual antiplatelet therapy. Dual antiplatelet therapy remains mainstay of treatment in post-acute coronary syndrome who received coronary stents. Eptifibatide and tirofiban are used in an IV form in acute coronary syndromes. They are glycoprotein 2B and 3A inhibitors. A table showing the irreversible antiplatelet agents that includes aspirin, clopidogrel, prasugrel, and abciximab. The rest are all having reversible action. Coming to reversing the antiplatelet medications. These can be monitored by measuring platelet function assays, as we have discussed already, and TEG with platelet mapping. Desmopressin is considered to be one of the reversing agent. Desmopressin is diamino 8D-arginine vasopressin. It can be given in a dose of 0.2 to 0.4 milligrams per kg IV in over 20 to 30 minutes. Tranexamic acid may improve platelet function as well. Evidence is of fair quality, but it is a safe, inexpensive, and widely available drug. It is recommended to keep the fibrinogen levels high during antiplatelet medication usage because in reversing, nearly 150 to 200 milligrams per deciliter is considered because it helps in reversing the antiplatelet action. Coming to the criteria of a platelet transfusion. The antiplatelet drugs should cause permanent inhibition of platelet function. The drugs which do this include aspirin, clopidogrel, and prasugrel. Wherever the conditions we need immediate hemostasis, we do go with platelet transfusions. For example, IC hemorrhage. Are they really effective? Platelet transfusions, we have to consider, are they really effective? The antiplatelet drug itself should already be cleared from the body. Otherwise, residual drug may cause inhibition of the new platelets. It is most effective for aspirin as this drug causes permanent inhibition of platelet function and has a very short half-life. Intermediate effect is there for clopidogrel because this drug causes permanent inhibition of platelet function and has a moderate half-life of 6 hours. Thus, if the patient took a dose of clopidogrel within last 6 to 12 hours, residual drug could interfere with the transfused platelets. There will be minimal effect with ticagrelor. Ticagrelor is a reversible platelet inhibitor. So platelet inhibition is a reflection of the real-time serum drug levels of ticagrelor. Transfused platelets will there be inhibited by ticagrelor along with native platelets adding little benefit. Coming to other causes of perioperative coagulopathy, vitamin K deficiency, which may be secondary to decreased vitamin K absorption or poor nutritional intake, or patients who are on broad spectrum antibiotics may be having gut bacteria dead, which can decrease the absorption of vitamin K, poor nutritional intake as we have told. And it can be measured by INR, which raises up, vitamin K deficiency, INR increases. The treatment part of it, 10 milligrams of vitamin K IV is considered. In the last mode, in the last modality, fresh frozen plasma and PCC for immediate replacement of clotting factors. Coming to uremic bleeding. Etiology of bleeding in uremic patients is likely multifactorial, but is mostly related to platelet function. Uremic coagulopathy is an indication for emergent dialysis if time allows. If a procedure is considered urgent or emergent and dialysis is not feasible, desmopressin may be given either intravenously, intranasally, or subcutaneously. It acts by releasing von Willebrand factor, which promotes platelet thrombus formation. Tranexamic acid and factor 7 shown to have some safe and effective role here. Word about FFPs. 1 unit of FFP is having 250 to 300 ml in it. We usually consider giving 10 to 20 cc per kg of FFP, which equates 3 to 6 units of FFP. INR should be taken into consideration while giving FFP. If INR is in between 2 to 3.9, we can consider taking 10 cc per kg of FFP. And if it is between 4 to 6, we need to consider 12 to 15 cc per kg. And as the INR increases, the dosage increases. Remember, with FFPs, it is impossible to achieve INR less than 1.7 because it contains clotting factors, but not in concentrated forms. Coming to prothrombin complex concentrate, they are derived from human plasma, contains factor 2, 11, and 10. 2, 9, and 10, sorry. With or without significant levels of factor 7. Also contains varying amounts of protein C and S. PCC products, there are considered to be 3-factor PCC and 4-factor PCC, which 3-factor PCC contains factors 2, 9, 10, and low levels of factor 7. 4-factor PCC contains factor 2, 9, 10, along with that higher levels of factor 7. To immediately reverse the effect, 4-factor PCC has to be considered because it is having a higher levels of factor 7. An activated PCC contains 4 coagulation factors. Along with that, an activated and inactivated forms of factor 8 inhibitors bypassing activity. A word about PCC infusion, depending on the INR. INR, if it is between 1.5 to 2, 15 units per kg of PCC has to be considered. That comes out to be maximum 1500 units. As the table shows, as the INR increases, the dosage of PCC has to be increased. Take-home message. Hemostasis is a complex, tightly regulated balance between bleeding and clotting. Through the use of anticoagulant agents, patients can be made to bleed, and with reversal agents, some of which are procoagulants by nature, patients can be forced to clot. In each of these situations, the harms and benefits should be weighed in the best interest of the patient and situation. Hopefully, in the near future, safer anticoagulants and more specific cost-effective reversal agents will become available, along with easy access to specific testing that can guide our use of these powerful medications. Thank you.
Thank you. Thank you, Dr. Manjusha, for making this complex topic lucid. It was a very lucid presentation. Is Dr. Devatiyas there? Zoom link?
Yes, I'm here.
Yes, sir. So would you like to add anything, sir, from your vast experience of various oncologic procedures and coagulopathy, and what you use and your experience, sir?
I think almost all the relevant points have been covered. I think we are going to see more and more of these patients, especially on the the novel oral anticoagulants. And unfortunately, the reversal agents for these two, for apixaban and for dabigatran, they are adalimumab and andexanet. Both are extremely expensive, andexanet alpha. And I think and also the monitoring, especially antitenia activity, is routinely not available in most sort of places. And so the management of bleeding from these agents, especially if there is bleeding, is actually quite tricky. If you want to just prepare a patient for surgery, it's not a huge problem because there are reasonably good guidelines. You stop X number of days prior. But if bleeding occurs with any of these agents, it could present a potential problem for reversal of these agents. Dabigatran from that point of view is dialysable. So maybe if you dialyze, then you can get rid of dabigatran reasonably easily with dialysis-free dialysis, with heparin-free dialysis. So, but otherwise, I think so. There's one situations where you prepare the patient for surgery, and you have enough time for elective surgery. Then all the guidelines that are there for all these agents come into play, and preparation for emergency surgery, where you have less than a day or a few hours to prepare. I think all the points that were made were extremely relevant, and so And fortunately now we have things like uh, cofactor PCCs are available. We also have tranexamic acid, of course, is easily available. We also have fibrinogen concentrates, which are now easily available. So it's made our life easier in terms of managing these sort of things. But when you come to bleeding, especially with the longer acting, with the NOACs, that can present a problem because the reversal, you just have to give our usual sort of agents and hope that things come under control.
So, do you have any experience in monitoring platelet function by PFA in your hospital? Because we have this PFA here, but I don't know, not it does not often correlate with the platelet function.
So we don't have platelet factor activity. We don't have that. We don't do it. But I think thromboelastography or some viscoelastic,
Yeah.
they work pretty well and are quite reliable. So one of the places where this sort of comes into play is, after a major liver resection, when the coagulation especially if you're monitoring the INR, you find that it is raised on the third day and fourth day, and the question comes of removing an epidural catheter. And very often you see that the INR is 1.7, 1.8, and people are hesitant to remove. I think it's important to understand that in liver resection or chronic liver disease, the low INR only reflects one part of the pathway, that is the anticoagulant pathway. There is also the procoagulants that are, that their levels may also be raised. And so the balance is often quite good. And you actually have to consider the balance between the procoagulants and the anticoagulants in the setting of a major liver resection, which are both are decreased, in after a major resection. And so the viscoelastic testing is quite useful. And there are times when the INR is on the slightly on the higher side, but the viscoelastic tests are quite good, and we are confident to remove epidural catheters, even do a small procedure or something in these patients.
My colleague Dr. Kiran, I think he often encounters this situation wherein the INR is on 2.2 or 2.5, and we keep the catheter for a day extra. Probably one good thing that we learned from today, from your experience, is just do a thromboelastography and pull out the catheter if the patient goes beyond 3. Would you like to add anything, Kiran?
Often we see INR is elevated in patients, especially post-surgical gastro patients, especially in those patients where the choledochal cyst is liver resections. We use cephalosporin sulbactam as a surgical prophylactic antibiotic, which itself can cause hypoproteinemia. So in those patients who are receiving this particular antibiotic also will have this elevated INR. So in such circumstances, what we do is on second or third post-operative day, we give vitamin K if it is coming down, like there is downtrend, like if it initial INR is 1.8, 1.9, now today it is 1.7, 1.6, we can safely remove the epidural catheter. We must have removed nearly 100 to 200 epidural catheters with an INR of 1.6 to 1.7. And luckily none of them had any complications after removal. And if the INR is more than 2, probably we are waiting for a day or two, and in situations like where we will have to shift the patient to what we ended up giving FFP, which may not be the right practice. So henceforth, if the patient can afford, probably we can do viscoelastic testing, and depending on that, we can decide when to remove the epidural catheter.
I think if you're considering giving FFP after liver resection, not for hypothrombinemia because of, say, cephalosporin or something, but because the INR, then after liver resection, you have to see the balance between your procoagulants and your anticoagulants, and the INR only reflects the anticoagulant pathway. So if you can remove the INR epidural at 1.8 or 1.7, but if you want to be really confident, do a TEG. And if you're thinking of an FFP, because someone tells you INR is 1.7, give FFP, for God's sake, first do a viscoelastic test before you even touch that bag of FFP.
Yes, sir. I completely agree with the concept of rebalanced homeostasis in liver patients. Yes, we don't give like FFP for all patients. We give FFP in patients without this background of CLD or liver resection patients, especially in those patients INR gets elevated because of other various reasons like cephalosporin sulbactam. And for liver resection, we understood the concept of rebalanced homeostasis.
And sir, before this thing, routinely, not at least in a hospital, but many of them, they have a routine way of doing BT-CT before surgery. Does it have any relevance in current practice, sir? Bleeding time, clotting time, as a part of routine surgical profile. Of course, we stopped doing it, but some of our surgical colleagues, they still write BT-CT as a part of profile. Would you like to discuss anything on this, sir?
I'm not sure what is there to discuss in this, but if you don't have anything at all, you do a bleeding time, clotting time, but otherwise, it makes more sense to sort of see the individual components that lead to the problem and do that sort of thing.
Thank you very much, sir. We'll just move on to the next topic.
Our next topic is on recovery from anesthesia, the change paradigm, by Dr. Trupti Gupta. She did her MBBS from Kamneni Medical College, Diploma in Anesthesiology from Osmania, and DNB from Medanta. Over to Trupti.
Thank you, sir. Good afternoon, everyone. Today, my topic of talk is recovery from anesthesia, the changing paradigm. So what is recovery? It is defined as a state of consciousness of an individual when he is awake or easily arousable and is aware of his surroundings and identity. Recovery is a continual process, and patient cannot be considered fully recovered until they have returned to their pre-operative physiological state. So what are the phases of recovery from anesthesia? There are 3 phases. First one being immediate phase. This lasts for a very short time. This consists of a return of consciousness, recovery of protective airway reflexes, and resumption of motor activity. Second phase is intermediate phase, which lasts for around 1 hour. The patient regains his power of coordination and the feeling of dizziness disappears. And the third phase is long-term phase. This is a full recovery of, there is full recovery of coordination and higher intellectual function. This may last for hours or even days. So recovery is a very critical part of post-op management. It can influence the outcome of any surgery. Timely recognition with appropriate clinical monitoring and the management of it can be life-saving. Likelihood that the specific complication will arise is determined by the nature of the procedure, the anesthetic technique used, the patient's comorbidities, and preoperative medical assessment and optimization of the patient. So our aim as an anesthetist is to have an awake, cooperative, and comfortable patient who is well perfused with an adequate amount of oxygenated blood. Anesthesia is a very safe procedure, but still because of patient's comorbidities, there can be some issues during recovery. This is the list of issues. The most common being postoperative nausea, vomiting. This is frequently seen in young females. The contributing factors can be surgical factors as well as anesthesia drugs. The second most common is respiratory complications, including upper airway obstruction, laryngospasm, stridor, coughing, aspiration, negative pressure pulmonary edema, and etc. The third most common is cardiovascular complications with BP alterations like hypertension, and arrhythmias. This is usually common in patients with coronary artery disease. Delayed recovery from anesthesia, usually seen in sick patients who are posted for emergency surgeries, who have electrolyte disbalance or with acid-base imbalances already preoperatively. Emergence delirium, common in elderly patients. Temperature derangements like hypothermia, this is usually seen after long or major surgeries. And inability to void, the contributing factor here can be the opioids that are usually used during neuraxial anesthesia for perianal or gluteal surgeries. Today, my focus would be on can we achieve neuromuscular blockade, total recovery, 100% recovery without any residual blockade, or can we avoid recurization? And to establish CERA, that is complete recovery after anesthesia. Can we achieve it? We all know about ERAS, that is enhanced recovery after surgery. This is the protocolized scientific pathway which is applied to boost the outcome and enhance the recovery phase after surgery. This is a standard worldwide. It started for usually the protocols were started for colorectal surgeries, that is GI surgery. Slowly the guidelines were published for various surgeries like bariatric surgeries, ERAS B, for thoracic surgeries, that is ERAS T, and for even cesarean sections, that is ERAS CS. Slowly for orthopedic surgeries also. Later on in 2016, there was Iraq ladder that was published in Saudi Journal of Anesthesia. This is Enhanced Recovery After Anesthesia. In this, they have focused very nicely about what is the role of anesthesiologist in the ERAS protocol, including the background, preoperative, intraoperative, and postoperative management. So at AIG, since last 5 years, by continuous dashboard audits, we have been successful in implementing the paradigm shift in ERAS in our department. We have moved even a step beyond ERAS. We are following ERAS E, that is from the point of extubation. While doing so, we have realized that yes, it is possible to have complete recovery of after anesthesia, not only enhanced, we can have complete recovery. So to understand and achieve complete recovery after anesthesia, an anesthetist should understand briefly about neuromuscular junction physiology, neuromuscular blocking agents, their mechanism, as well as the factors that is affecting it, the factors that are affecting the recovery of the patient, and the causes of delayed recovery. Starting with neuromuscular physiology, we know that the muscle fibers are innervated by the axon of motor efferent. This is the picture of a neuromuscular junction. The main transmitter here is acetylcholine. Whenever there is action potential because of the calcium influx, the acetylcholine vesicles are released into the synaptic cleft, that is the junction between the two membranes, and then these goes and attach to the acetylcholine receptors. Whenever they attach to the acetylcholine receptor, the sodium is moved inside the cell and potassium moves outside. This is important clinically. See, basically acetylcholine receptors, they have 5 subunits, including 2 alpha, 1 beta, 1 epsilon, 1 delta. When this epsilon is replaced by gamma, usually during burns, sepsis, immobilization, or motor neuron disorders, this is epsilon is replaced by delta gamma. So what happens is that there is excessive outflux of the potassium, and there will be hyperkalemia in such patients, and thus we should avoid scoline in these patients. Now coming to neuromuscular blocking agents, this is a classification of neuromuscular blocking agents. They are divided into 2 types, depolarizing and non-depolarizing based on mechanism of action. So depolarizing example is scoline, which is regularly being used. Here this scoline mimics acetylcholine and attaches to the acetylcholine receptor. The only difference is that this is resistant to the degradation by acetylcholine esterase, and thus there is continuous depolarization of the muscle fiber. And thus the next neuron transmission is not transmitted towards the muscle, and the muscle is paralyzed. This is phase 1 blockade. Sometimes when we use high doses of scoline, or when there is repeated doses, or when there is infusion of scoline, because of the availability of scoline, which is more at the neuromuscular junction, the sensitivity of the acetylcholine receptor reduces, and thus the patient goes into phase 2 blockades. Clinically, this is important because whenever the patient is not coming out of scoline or not breathing after scoline blockade, we should consider this in mind, and we should do neuromuscular monitoring. In this, the patient's neuromuscular monitoring will show as a picture of non-depolarizing muscle relaxation. Coming to non-depolarizing blockers, again they are divided into 3 types based on the duration of action. We regularly use intermediate acting, that is etracurium, cis-etracurium, rocuronium, vecuronium. The mechanism of action is, this is just competitive. They go and attach to the alpha subunit, and thus there is no transmission, and there is a paralysis of the muscle. The important point here is the metabolism or elimination. For example, scoline, this is metabolized by plasma cholinesterase. When the patient has atypical plasma cholinesterase or reduced amount of plasma cholinesterase in the body, the duration of action of scoline increases. Next, etracurium and cis-etracurium, they are not dependent on renal or hepatic physiology of the patient. This is eliminated by Hoffman elimination. Whereas vecuronium and rocuronium, we should be very careful while using in patient with hepatic and renal dysfunction, because their metabolism and elimination depends on this system. Now, very important factor for recovery, we should understand that very many factors affect non-depolarizing agents. There are factors that potentiate the action of non-depolarizing blockers. For example, hypothermia, acid-base disbalance like respiratory acidosis, electrolyte abnormalities like hypokalemia, hypocalcemia, and hypomagnesemia, extremes of ages like neonates and elderly, excessive volatile anesthetics, renal and hepatic failure, and conditions like acute intermittent porphyria and Eaton-Lambert syndrome and myasthenia gravis. Whenever we are having any of these patients, we should consider that there can be residual neuromuscular blockade, there can be delayed recovery in this patient. So we should always see to it that there is normothermia, there should not be any acid-base disbalance. The electrolytes, whenever we get doubt, we should check for it through ABG and correct them. And there are certain factors which antagonize the actions of non-depolarizing NMBAs, that is alkalosis, hypercalcemia, demyelinating lesions, peripheral neuropathies, denervation states, infection, immobilization, and muscle trauma. So there are certain drugs which also affect our neuromuscular blockers. The drugs which potentiates the actions are antimicrobials like aminoglycosides, tetracycline, polymyxin, cyclosporin, and clindamycin, alpha blockers and calcium channel blockers. Some drugs like cyclophosphamide, dantrolene, diuretics, inhaled and local anesthetics, and lithium and magnesium and quinidine. So whenever we are doing during the PAC itself, we should have a detailed history of the patient, what patient is taking, and during interop also, if we are using any of these drugs, we should be having in keep in mind that yes, this patient can have longer duration of action, this patient can have residual neuromuscular blockade. So there are certain drugs which antagonize non-depolarizing blockers, that is anti-seizure drugs like carbamazepine and phenytoin, ranitidine, theophylline, and aminophylline. So what is residual neuromuscular block? It is defined as the presence of sign or symptom of muscle weakness in a post-operative period after the intraoperative administration of NMBAs. So incidence ranges almost from 5 to 50%. Recuralization, it is defined as an increase in the neuromuscular block after a variable period of recovery. So according to a recent meta-analysis, after long-acting blockers, if we are using, almost 20 to 50% chances of recuralization is there. And if you're using intermediate-acting drugs like etracurium or cisatracurium, the chances are 0 to 12%. So usually we know that patient takes 45 minutes to 2 hours to attain the same strength as preoperative period. And this I'm talking in a patient with no underlying myopathy or nutritionally fit patient. So how do you evaluate such patient? How do you evaluate the recovery? Quantitatively, we assess for the responses to nerve stimulation by measurement of the evoked mechanical response of the muscle, that is mechanomyography, measurement of the evoked electrical response of the muscle, that is electromyography, EMG, the measurement of acceleration of the muscle response, that is aceclomyography, and measurement of the evoked electrical response in the piezoelectric film sensor, that is piezoelectric neuromuscular monitor, as well as phonomyography. Now coming to qualitative evaluation, usually we use this clinically very often. There are 5 patterns of nerve stimulation: single switch stimulation, train of 4, which is most common among these, tetanic stimulation, post-tetanic count, and double burst stimulation. Coming to single switch, here we give a single supramaximal stimulus to the muscle and then we check for the response. Clinically, the importance is that the response, there is no difference in the amplitude of the response in both the depolarizing drug as well as non-depolarizing drugs. Only the duration is differing, as you can see in this picture. And coming to clinically, when there are 100% receptors are blocked, so the twitch height is only 0, whereas when there are 75% receptor block, that means only 25% receptors have recovered, the twitch response is almost 100%. So for a muscle to start functioning, 25% receptors are also enough. Coming to train of 4, which is being regularly used, here we give 4 supramaximal stimulus at the 2 Hz frequency, and then we see for the response. So when in this picture, as we can see, there is no block or the non-blocked muscle, the response ideally should be, all the 4 responses should be same. The 4th response is T4 and the first response is T1, and the ratio is called TOF ratio. Usually, so according to this, ideal ratio is 1. Whereas if there is depolarizing response, there is decrease in the amplitude, but the TOF ratio is again 1. In non-depolarizing, there is a fading scene, and the ratio will tell us about the recovery. That is T4 to T1. So clinically, when the patient's TOF ratio is less than or equal to 0.4, the patient is unable to lift the head or arm. Tidal volume may be normal, but still the vital capacity and the inspiratory force is reduced. This is to be kept in mind. When the TOF ratio is between 0.4 to 0.6, most patients are able to lift their head for 3 seconds, open their eyes widely, stick out their tongue, but still the vital capacity and inspiratory force are often reduced. From 0.7 to 0.75, the patient will have diplopia and visual disturbances. There will be decreased hand grip, strength, inability to maintain the position of the incisor teeth. The tongue depressor test is negative, inability to sit up without assistance, and there is severe facial weakness. Speaking is often a major task here, and overall there is weakness and tiredness that is felt by the patient. When it is 0.8 to 0.9, the vital capacity and inspiratory forces are normal. Diplopia and visual disturbance are still present, and generalized fatigue may be there. So TOF ratio, according to many analyses that have been published, of at least 0.9 is considered as an adequate level of muscle recovery. There is another entity called TOF count. Here we see the number of evoked response that are detected rather than the ratio. As you can see in this table, here when there are 100% neuromuscular blockade, the TOF count is 1. And whenever there is, like as the number of responses increases, it increases with the number of receptors that are being unblocked. There are other entities like tetanic stimulation, post-tetanic count stimulation, double burst stimulation. Overall, I would just like to say about these are not regularly being used because of the painfulness, the pain that patient faces. Second thing, here we can just differentiate between the non-depolarizing and the depolarizing blockade. In the depolarizing, there is no fade, and in non-depolarizing, there is fade. So where do you do, where is it is essential to do neuromuscular blocking, monitoring? Whenever we are using prolonged infusions or when we are using long-acting neuromuscular blocking agents, whenever there is prolonged surgery or anesthesia, when inadequate reversal may have devastating effects, like in patients with respiratory disease or morbid obesity. In condition where you don't want to give any reversal agents like neostigmine or like other anticholinergics, which can cause harm, for example, tachyarrhythmias or cardiac failure. In patients with liver or renal dysfunction, in patients with neuromuscular disorders, and surgeries where you don't want any movement of the patients like neurosurgery or vascular surgeries which are very near to the vital areas. So after understanding this basic detail, I just like if there's a case scenario, after the end of the case, a patient has recovered well, obeying commands, maintaining SpO2 and holding the airway also. Does this mean that the patient is completely reversed from the neuromuscular blockade? Is there any residual blockade? And if yes, how do you quantify it? So obviously, we have to assess. And assessment can be done clinically as well as quantitatively and qualitatively. Qualitative and quantitative evaluation I have already discussed. Clinically, there are certain tests which have been described. Some tests are unreliable and some are most reliable. Unreliable include sustained eye opening, protrusion of the tongue, arm lift to the opposite shoulder, normal tidal volume, normal or near normal vital capacity, and maximum inspiratory pressure less than 40 to 50 centimeters of water. More reliable would be sustained head lift for 5 seconds, sustained leg lift for 5 seconds, sustained hand grips for 5 seconds, sustained tongue depressor test, and maximum inspiratory pressure more than 40 to 50 centimeters of water. So lastly, we will just cover the causes of delayed recovery. Whenever we find any of these causes, we should be very careful and we should be considering about this and during the time of recovery. There are factors like patient factors, extremes of ages, gender, genetic variation, comorbidities, body habitus, cognitive dysfunction, seizures and stroke. Some drug factors like when was the dose, what was the dose given, what was the time of administration, blood gas solubility of the drug, metabolism and excretion of the drug, interactions, fluid overload, and factors like the duration of surgery and anesthesia, the muscle relaxant that was being used, hypotension, hypoxia, embolism, cardiac and neurosurgery, regional techniques with sedation and painful stimulation. Metabolic factors like hyperglycemia, hypernatremia, hypothermia, hypothyroidism, hepatic and renal dysfunction, central anticholinergic syndrome, acidosis and coagulation defects. So with all the details that I have discussed about the neuromuscular physiology, neuromuscular blocking agents, the causes that affect the blocking agents, that there are causes of delayed recovery, can we still achieve complete recovery after anesthesia? Yes, we can achieve with the use of modern day anesthetic use, with predefined perioperative clinical pathway, which are starting right from the time of PAC, with using intraoperative managements like opioid restrictive anesthesia, we at acting opioid agents. We have opioid-free anesthesia as a kind of technique for our anesthesia, and we regularly use dexmedetomidine infusion because it gives beautiful depth of anesthesia with very short duration of action. Regularly, we do regional anesthesia whenever there is feasible, and with focus on sensory blockade as a part of multimodal analgesia. We use short-acting drugs, wherein we even avoid benzodiazepine, include midazolam. There is always a right balance that we use between inhalation and TIVA, which is bis titrated. We prefer using desflurane over sevoflurane and isoflurane. I understand there are many studies being published regarding the greenhouse effect that is caused by desflurane and anesthesia gases. But with the amount of the anesthesia drugs and the desflurane that we are using, the effect on the greenhouse or the ozone layer is very low. That is just very abysmal. And newer reversal agents like Sugammadex is being used. We are awaiting the launch of remifentanil and planning to evaluate liposomal bupivacaine, which is right now very not available that freely and is very expensive. So this is just an idea about how we do cases at AIG. Just a glimpse about it. This is a 33-year-old female who ASA1 who was posted for laparoscopic umbilical hernioplasty. Preoperatively, after her basic assessment, we check for the muscle strength using dynamometer. Intraoperatively, as you can see in this picture, we do neuromuscular monitoring as a norm. We use bis titrated anesthesia, opioid restrictive anesthesia, where desflurane is regularly used. During extubation, we do, after neuromuscular monitoring, we check for this TOF ratio. As you can see here, it is almost 68% in this patient. I have given her Sugammadex now. We have used rocuronium in this patient. After giving Sugammadex, after few seconds only, we will see that there is good muscle strength of this patient and patient has started breathing. And before that, I will check for the neuromuscular monitoring and check for her TOF ratio. As you can see here, when I'm checking for the TOF ratio, it is showing 106, that is more than 100%, and now I can reverse my patient without any worry of residual neuromuscular blockade or without any worry of recurrization. Postoperatively, my aim is to attain same muscle strength like preoperative, and that's why I'm checking for the muscle strength in the with the dynamometer help. So what are we achieving by doing all this? I'm achieving a 0-hour sitting and ambulation, perhaps 0-hour sips of water if there is no contraindication from the surgical site. We are minimizing the chance of DVT. We are having fasted nutrition supplement postoperatively with reduced ileus, reduce postoperative complications, pulmonary complications, and thereby reducing the burden of surgical ICU and my colleague Dr. Kiran, and reduce need for physiotherapy. I'm not trying to demean any specialty here, but yes, physiotherapy is very important part of postoperative management, but still we can reduce the need if you are following SERA protocols. And reduce ICU and hospital stay and cost, thus balancing the cost of Sugammadex and having improved patient satisfaction. While doing all this, we always keep in mind about the problems. Why don't we step ahead and make it a norm in all the cases? With SERA and ERA-C in place, we have patients who have walked, pediatric patients especially, who have walked directly into the arm of their parents, who this is the patient who has been taking sips of water immediately in the postoperative period. And yes, so can we achieve no neuromuscular blockade at residual blockade? Yes, we can. Can we avoid recurrization? Yes, we can. To achieve SERA should be a new normal. Thank you.
Thank you for making this presentation. Just for the sake of audience who are listening to us. Hello. Yeah. for listening to us. I must tell that we have been practicing this ERAS-E and SERA of late, almost for more than a year now. And yes, select few cases at the moment. We have gone up to ASA grade 3 patients also now, and fantastic results in terms of early ambulation and early on their feet, which is very pleasing for the attendants especially. I really don't know as of now whether we have really reduced the incidence of DVT, but definitely one thing that we have seen and we have audited is the enhanced patient satisfaction. So, Dr. Devatiyas, if you would like to add anything to this?
Yeah, so again, these are the things we must aim for, whether it's SERA or ERAS or ERAS-E. And of course, the idea should be that the patient should be up and about as soon as possible after the surgery. Also eating and drinking and
In fact, when I was doing this protocol last 2 years back, I came across your study on ERAS and hepatobiliary pancreatic surgery from Tata Memorial. I think you were the primary author for that.
I wasn't, it was a GI group, they were doing it.
But I think you are one of those. The thing is, again, one of the controversy for ERAS is this epidural versus no epidural. What do you say on that, sir?
So, yeah, so there are some surgeries for which epidural is clearly better as far as the analgesic is concerned. Okay. Especially if you and so on and so forth. But of course, then the problem with epidural is you have muscle, you have weakness, you could have limb weakness, and also what happens after many GI surgeries is that you do epidural, you also do a little bit of fluid restriction, or at least you tend to be a little more on the conservative side for fluids, and then you make the patient stand and start walking, and then there's a chance of hypotension, and then you need to start a noradil infusion and all those kind of things. So you have to balance things out, and
Absolutely.
you can see we'll avoid the epidural and we'll give a tap. That's good, and then you have to give more opioids or some supplements and so on. So you have to balance it out, and I
Yes, a right
think
balance.
it can easily be done, but it needs some work. And the other thing, apart from the immediate recovery and immediate walking, especially in cancer patients, because in cancer patients form a big chunk of your workload, is what we call as one of the aims of recovery, not just from anesthesia, but even the immediate post-operative period, is what we call as RIOT. That is return to intended oncological therapy. So the patient is fit and ready to receive the next sequence of therapy, which is usually chemotherapy or radiation therapy. So the recovery must not only be immediate, but it must be extended so that the patient stays well and is able to go home or be fit enough to receive his chemotherapy or whatever other sort of therapies that are there.
Thank you, Dr. Devatiyas. Thank you, Dr.
Thank you, sir.
Tripti. Next talk again, Dr. Devatiyas is an authority on this topic. In fact, he has several publications and several presentations. I must have listened to at least about a dozen of times the fluid management in GI surgeries or in general perioperative period, restrictive versus liberal versus goal-directed versus ROSE protocol, other things. So, Dr. Kiran, you can introduce the topic in the speak.
Topic is on perioperative fluid therapy and volume assessment by Dr. Bona Palluri. She did her post-graduation from NIMS. Over to Bona.
Good afternoon, everyone. I'm Dr. Bhuna, and I'll be talking about the perioperative fluid therapy and volume assessment. So, continuing from the previous talk, Trupti ma'am has told about the aim to have a recovered or awake patient is to also ensure that the patient is well oxygenated. So, oxygen delivery is possible with adequate fluid volume. That is, you need to have an adequate intravascular volume. So my topic is a fundamental concept which every perioperative physician will have, because especially in the trauma setting, wherein we'll be proactive in going ahead with resuscitation, especially when there is a fall in BP. We need to know a line wherein we have to shift from the fluid management to the vasoconstrictor agent in order to maintain the cardiac output. So this is a common practice for all the anesthesiologists, and I think my talk can provide further, can throw further light on this. So the objectives of my talk are to know about the goals of perioperative fluid management, to understand the physiology of fluid responsiveness and the parameters to assess it, and finally to know about the evidence-based recommendations on the intraoperative fluid management. So if we can see here, this is an inverted bell-shaped curve, and the margin which we have is very narrow. If we go to the left side of the curve, the patient will be hypovolemic, which leads to a low circulating volume, low blood pressure, low perfusion to the tissues, which results in organ dysfunction and organ failure. To the right of this bell-shaped curve is hypervolemia, wherein if we overload the patient, at the cellular level, there will be a breach in the glycocalyx membrane, which leads to tissue edema, which further impairs the tissue oxygenation. In the lung, it will pulmonary edema because of the disruption of alveolar capillary membrane and prolonged mechanical ventilation. And it also leads to dilution, which leads to coagulopathy. So the fluid management forms an important crux of our treatment in the OR and in the ICU, and both insufficient and excess can be deleterious. So this is again what I've spoken. In the GI system, it can lead to decreased motility, ileus, and can also cause anastomotic dehiscence. So the goals of perioperative fluid management is to replace the volume which happens, like in the hypovolemia, like in the preoperative period. Hypovolemia is mostly common because of the fasting, bowel preparation, bowel obstruction, and if there is any inflammatory pathology like pancreatitis, and this reduce the venous return. And if the duration of the surgery is prolonged, there can be more of the insensible losses. So in our hospital, mostly we do bowel preparation only for the lower GI surgeries. So a major chunk of the preoperative hypovolemia will be dealt with this method or whatever preventive measure, with this kind of preventive measure. So the goal of perioperative fluid management is to replenish this decreased volume and to improve the oxygen delivery and tissue perfusion. So if we can see here, the fluid therapy increases the cardiac preload, which increases the stroke volume, which increases the effective circulating volume, and hence increases the oxygen delivery to the tissues. So what are our challenges? Now we have got to know that the fluid management, whatever we are giving, it should improve the cardiac output. How much fluid has to be given? So we have to know an idea of how much deficit is there. In order to know that, we have to estimate the intravascular volume, which is often difficult because the pre-op volume status is unknown, and it is difficult to approximately or exactly quantify the ongoing surgical losses. Responses to the anesthetic agents are often changing because we'll be changing the doses of the agents. And the lab values can also not guide us properly because they give an impression about that particular point of time, not a prolonged thing. And the traditional methods like thirst cannot be used in an anesthetized patient. So in order to estimate the intravascular volume status and to know in whom do we have to push in fluid, we have to understand the concept of fluid responsiveness. This can be known via the Frank-Starling curve. This is a curve which is a relationship between preload and stroke volume. So if we can see here, it is divided into two parts. One is the steep part and other is the plateau part. So the steep part, wherein an increase in the fluid, like a fluid bolus, if it is given, it will give a vigorous response. Whereas once reaches the plateau part of the curve, even with a fluid bolus, there is very feeble response. So we have to understand where our patient is before pumping more fluid into him. And only 50% of hemodynamically unstable patients are fluid responsive. So now we have understood why there will be hypovolemia and how do we have to manage hypovolemia, like in which patient do we have to give fluid. In order to know in which patient do we have to give fluid, we have to know the parameters which give which assess the fluid responsiveness. So these are the parameters. This can be further divided into static and dynamic. The static parameters include blood pressure, heart rate, capillary refill, urine output, blood lactate levels, CVP, and mixed venous oxygen saturation. And the dynamic parameters include stroke volume variation, LV end diastolic pressure and end diastolic volume, stroke volume, cardiac output, and cardiac index. So these are the parameters which help in understanding whether the patient is going into hypovolemia or not. Like if the changes in these parameters can give an insight into the volume status of the patient. There is something called occult hypovolemia, wherein there will not be any changes in these parameters, but the patient will still be having reduced intravascular volume. This can be detected by NIRS, microdialysis, GI CO2, and pH measurement. Coming to static parameters, as said earlier, it includes heart rate and BP, and other things. So limitations are that these are neither sensitive nor specific, and hence has been removed from almost all clinical recommendations and goal-directed algorithms. Coming to CVP and pulmonary artery occlusion pressure have other factors like vascular resistance, intrathoracic pressure, and ventricular compliance affecting it. So there is no direct correlation between CVP to the fluid responsiveness. So static parameters should not be used to predict volume responsiveness. Coming to dynamic parameters are based on the heart-lung interactions. With the initiation of positive pressure ventilation, there will be changes in the intrathoracic and transpulmonary pressures, which will affect the loading of the both sides of the heart, the right and left heart. So it is like the dynamic parameters are derived from these cyclical changes with respect to positive pressure ventilation. For example, in inspiration, the right heart stroke volume will be decreased and the left heart stroke volume will be increased. The opposite happens during expiration. So the magnitude of the changes with respect to positive pressure ventilation will be very much higher if a patient is hypovolemia, is in hypovolemia. So the degree of this respiratory changes in stroke volume can be an accurate predictor of fluid responsiveness. Some other dynamic parameters are as follows. So if we can see here, this is a diagram depicting the difference between spontaneous breathing patient and a mechanically ventilated patient. In a mechanically ventilated patient, the degree of the pressure variations of intrathoracic and transpulmonary are very much higher, so that it can cause the difference in the loading characteristics of right and left heart. So the dynamic parameters can only be used in a mechanically ventilated patient. Coming to one dynamic parameter, which is systolic pressure variation. It's the difference between maximum and minimal SBP and is calculated with an arterial line. Because we are giving or basing our fluid management based on these dynamic parameters, it is important to have an accurate value of systolic blood pressure. So we take the help of arterial line, and it is calculated with the following formula. If there is more than 10% change in the SBP, it indicates that the patient is on the ascending portion of the Frank-Starling curve, and hence he is a fluid responsive patient. Ravinier and his colleague showed that SPV is a sensitive indicator of fluid responsiveness in patients with sepsis-induced hypotension. The next dynamic parameter is pulse pressure variation. It's the difference of maximal and minimal pulse pressure over the same respiratory cycle. It is also derived from the arterial waveform, and it is calculated with the following formula. More than 13% of PPV indicates that the patient is fluid responsive. It is the most extensively studied and is a more reliable parameter among all the dynamic parameters. So this is a pictorial representation. The first picture shows a difference in the pulse pressure maximum and the pulse pressure minimum. And this is a stroke systolic pressure variation. This is the maximum and minimum systolic blood pressure. The difference will give the systolic pressure variation. And next is a pleth variability index. Pleth variability index is advantageous in that it is a non-invasive method. It is only based on the pulse oximetry waveform. The principle of working of this is that in the systole there will be increased hemoglobin because of the increased stroke volume. Thus there will be decreased light absorption, and the opposite will be happening in the diastole. If the values is on the higher side, that means closer to 100, it indicates increased variability and invasive dynamic parameters like SPV and PPV. So it can be used as a surrogate marker. The disadvantage of using pleth variability index is that it requires offline recording and analysis. Thus it is difficult for real-time utilization. The next dynamic parameter is stroke volume variation. It's the difference between maximum and minimum stroke volume. It is obtained from pulmonary artery catheter, echocardiography, flow track, LIDCO, and PICO. Of these, flow track and LIDCO, they do not require frequent calibrations and thus provide a continuous SPV and PPV measurements. The drawback of using this is that for stroke volume variation calculation, the specific devices are needed and continuous calibration is a must. So that is a bit clumsy and it is costly also. So this is a flow track in our institute. So in here, we have to enter 3 parameters, like we have to take a sample from the ABG arterial line and the central line, have to enter the mixed venous oxygen saturation, SpO2 from the SpO2 and HB from the arterial line. After entering these 3 parameters, we'll get the derived values of stroke volume variation, cardiac index, and we can also calculate extravascular lung water. So this is a graphical representation. As said earlier, these are the derived variables in our flow track. So the limitations of using dynamic parameters are that the bases are the cyclical changes during mechanical ventilation. So it can only be used in patients who are mechanically ventilated. Tidal volume should be large enough so that it can cause significant changes in the intrathoracic and transpulmonary pressure. Patient should be in the normal sinus rhythm, because if there are any ectopics, it will lead to miscalculation. And the patient should have an enclosed chest cavity, normal intra-abdominal pressure, good arterial compliance, and normal LV and RV function. So these limitations of dynamic parameters can be replaced or overcome by using passive leg raising test and end expiratory occlusion test, mini fluid challenges, and transthoracic and transesophageal echo. So these are the tests which can replace PPV as a dynamic parameter. A special mention of to tidal volume challenge test, this credit goes to Dr. Devatiyas sir. So this is a parameter which will enhance the reliability of PPV in a situation where it cannot be used, especially in the ICU setup where the patient lungs will be bad and we cannot ventilate them with 8 ml per kg. This tidal volume challenge will help to take PPV as a dynamic parameter to know about the fluid responsiveness. So how this is done is baseline PPV is taken at 6 ml per kg tidal volume and it is noted, and a transient increase to 8 ml per kg is done for 1 minute, and a fluid bolus also. The patient who are more than 3.5, if we give a fluid bolus, the change in the PPV can easily be seen. So tidal volume challenge, it's a simple bedside test, does not require a continuous cardiac output monitoring. It overcomes the major limitation of PPV, making it reliable in predicting the fluid responsiveness in patients who are receiving low tidal volume ventilation. Next dynamic parameter is echocardiography. Echocardiography gives a direct visualization of the LV cavity. So the underfilling of the LV and the end diastolic and the systolic, end diastolic and end systolic volumes can easily be seen. So the subaortic velocity time integral can measure SV, and the measurement of end diastolic volume can be used as a surrogate for preload. More is the stroke volume and more is the preload. That means patient is on the steep part of the Frank Stalling curve and hence he'll be volume responsive. The disadvantages of using echocardiography is that it's not accessible everywhere. It requires an operator who has skill and it varies from individual to individual. Repeated testing is needed to know about the loading and the underfilling or overfilling of the LV, and it is costly as well. And the other thing which we can use is ultrasonography to assess the IVC diameter and collapsibility. This is mostly used in spontaneously breathing patients. The advantage is be used in spontaneously breathing patients. So this is a recent study which is published in the Journal of Clinical Medicine, which evaluates the role of IVC sonography for volume status evaluation. So in the IVC also there is a static and a dynamic parameter. The static parameters are diameter and collapsibility. A diameter of more than 2.1 and less than 50% inspiratory collapse indicates a high right atrial pressure of 22. 10 to 20. So IVC is a major capacitance vessel of the body. Almost 85% of the plasma volume is 85% of the body volume is in the venous circulation, and IVC is a major capacitance vessel, and it is also a direct continuation of the right atrium. And right atrial pressure monitoring always formed a cornerstone of fluid management. So while seeing IVC, we target to look at the right atrial pressures. The dynamic parameter is collapsibility of the IVC. Collapsibility of the IVC more than 40 may be useful in predicting the volume responsiveness. In order to increase the diagnostic accuracy of less than 50 plus a standardized inspiratory effort can be used. So distensibility of IVC has a better prognostic performance than collapsibility. The pitfalls of using IVC ultrasonography is that it has complex pathophysiology. Like there are many interrelating factors like pregnancy, ascites, and if it is a chronically dilated IVC, TR, right heart failure, it cannot be used in such kind of patients, and it cannot be used as a sole measure to understand the volume status. It has to be only used in a combined manner with heart, lung, portal, splenic, and renal vein. So ultrasonography of IVC cannot be considered as a standalone method to assess the volume status. So in order to improve the reliability of IVC, we have this study has integrated a passive leg raise test. So they have hypothesized that IVC collapsibility index and coronary artery blood flow would change predictably in response to passive leg raise, thus it providing a non-invasive tool to identify fluid responsive patients. The results of this study are quite promising, wherein passive leg raise test was associated with a significant reduction in the collapsibility index, and the mean stroke volume also increased. The changes in the physiology, like the disadvantage of this is that with the passive leg raise test, whatever are the changes in the collapsibility of the IVC, they are very short-lived. Like it doesn't even give us much time in all the subjects to measure the significant change that it has caused in the collapsibility index. So this is one study, and coming to passive leg raise test, it can also be incorporated into the calculation of velocity time integral to improve its accuracy. So this is a normal velocity time integral of an echo patient, wherein he has come in with a velocity time integral of 13.6, that is aside. So this is in a semi-recumbent position. After doing passive leg raise test, the velocity time integral has increased to 16. From 13.6, it has increased to 16, which indicates a 15% increase, which shows that the patient is fluid responsive. Lung ultrasound, this is to know about the volume overload status. These are the pleural lines. These are the B lines which are arising from the pleura. So 2 per each intercostal space is normal. If at all the patient is on the right side of the inverted bell-shaped curve and is going into interstitial edema, then there will be appearance of multiple B lines. So like lung ultrasound can be used to evaluate the volume overload status. Now we have learned about, like till now we have known about why do we have to give fluids, and in which individuals do we have to give fluids, who are fluid responsive or no, and what are the guiding parameters to give the fluid, and now we'll know what kind of fluid do we have to give. On a broad basis, they are divided into crystalloid, colloids, blood and blood products. Crystalloids, again, balanced and unbalanced solution. Balanced solution maintain the acid-base balance, and unbalanced solution doesn't, and 0.9% NS is an example of that. So for major surgeries, we give around 3 ml per kg to replace the sensible and insensible losses and support the basal metabolic rate. Bolus for a crystalloid is 250 ml. In order to replace blood, it is given in a ratio of 1.5:1, and a dextrose containing balanced crystalloid is usually avoided. So use of balanced crystalloid is appropriate to maintain normovolemia, especially if you are going for a large volume infusions. So these are the few trials which have compared balanced crystalloid to an unbalanced crystalloid. There are controversy regarding the results, but usually we go for a balanced crystalloid in the ICU as well as in the OR setup. Coming to colloids, as we know, the human albumin derivative and the synthetic. So the advantages of colloid is well known. It stays in the intravascular compartment for a long time, which avoids further fluid bolus and the vasopressor requirement. The disadvantages is that with gelatin, it has a high risk of anaphylaxis and it has a short duration. HES has a significant effect on coagulation, so it further leads to infusion of FFPs and cryo in order to correct it. And albumin is expensive. Usually here in all the hepatobiliary surgeries, if needed, we go for a 20% albumin infusion. Blood transfusion, once the transfusion trigger is met, we infuse RBCs, and plasma is given only if there is intractable bleeding. And FFPs should be as replacement for colloid should not be used, and it should be used only in abnormal coagulopathy. What kind of fluid management strategy should be given? This is dependent on what is the fluid that we are giving and the invasive or non-invasive monitoring. So this is it depends on the expected blood loss, where the patient is going. If the patient is going to a ward, usually will not go for an invasive monitoring. If the patient is he has the congestive heart failure, usually we'll go with we don't overload the patient with fluid. We go for a vasopressor support and all that. So for a minimally or moderately invasive surgery with planned early extubation and non-significant fluid losses, 1 to 2 liters of balanced electrolytes electrolyte solution over a period of 30 minutes to 2 hours will address the mild dehydration caused by preoperative fasting. For a major surgery, there are two kinds of fluid management strategies. One is a restrictive zero balance and other is a goal-directed fluid therapy. We usually go for a goal-directed fluid therapy. Restrictive zero balance is used in a major invasive surgery with an expected blood loss of less than 500 and when no invasive monitoring is planned. Again, a balanced electrolyte crystalloid is given at the rate of 3 ml per hour. Blood loss, if it is more, third space losses. So this is the optimal crystalloid to blood ratio as said earlier, and if you are going for a colloid, it is 1:1. Preloading is avoided, and extremely deep plane of anesthesia is also avoided in the restrictive balance, and if at all there is the etiology, and hypovolemia may not be clinically appreciated when following this regimen. So in order to overcome these things, there is a modified approach called restrictive deferred hydration, wherein a restrictive approach in 1 ml per kg per hour is given along with a low-dose norepinephrine infusion during the initial portion of surgery, which is followed by hydration during the last portion of the surgery. This is done in cystectomy patients, and it has shown that the patients have fewer complications and duration of hospital stay. Goal-directed fluid therapy, we usually go for a goal-directed fluid therapy. So in major invasive surgeries, anticipated blood loss of more than 500 with fluid shifts, and when one or more non-invasive monitoring is used. So goal-directed fluid therapy is directed towards specific goals, which we have already discussed in the dynamic parameters. So before adding a vasopressor, optimal fluid status is ensured. And we can go for an intraarterial waveform in order to know the SPV, PPV, and for high-risk output monitoring in the form of flow track, esophageal Doppler. Goals that we target, as already discussed, these are the dynamic parameters. So this is the same. If SPV and PPV is 10 to 15%, give a fluid bolus until they are less than 10. Same applies for the stroke volume, and if TT like trans-esophageal echo is used, we can directly visualize the changes, and the response to fluid bolus can also be seen in real time. So this is the algorithm. SVV is measured more than 13, give a fluid bolus, less than 13, and the MAP is maintaining. We observe if MAP is less but SVV is less than 13, consider going for a vasopressor in order to maintain the cardiac output. Comparison with traditional liberal fluid, it reduced mortality, hospital stay, reduced risk of postoperative pulmonary complications. But goal-directed fluid therapy compared with restrictive fluid strategies, there is very limited data available. And in a high-risk surgical population, G2 modality, because it significantly decreases the postoperative mortality and morbidity and mortality. Limitations are that compared to SPV and PPV, stroke volume and cardiac output directed GDT is more effective, which is costly as well, and it does not appear to have additional benefits over restrictive approach for a patient managed with ERAS protocols. And the endpoints like when to start the GDT, what are the combination of therapies like fluid with vasopressor or fluid around, and how long should the regimen should be continued into post-op is less well defined. Coming to perioperative deresuscitation, this model is described by Malbrain and colleagues. And there is a ROSE concept called resuscitation, optimization, stabilization, and evacuation. So if we see here, resuscitation, this is an aggressive phase wherein volume will be administered to the patient in order to treat the perioperative hypovolemia. Optimization, wherein we start for a plateau phase and aiming for a neutral fluid balance. In stabilization phase, from the neutral fluid balance, we'll go to a negative balance. And in evacuation, we go for an aggressive negative balance therapy by employing our renal replacement therapy and diuretics. So it can, it is also hypothesized that this perioperative deresuscitation favors the recruitment of microcirculation. ERAS protocols in preoperative period avoid prolonged fasting, avoid unnecessary bowel preparation, and encouraging patients to have a clear carbohydrate drink. In the intraoperative period, avoid excess salt and water to maintain euvolemia. And every patient should have an individualized fluid management plan. Usually we go for a goal-directed fluid therapy, and excessive crystalloids are avoided for all the patients. Post-operative, the goal is to have early post-op alimentation and ambulation. In some low-risk patients undergoing low-risk surgery, zero balance approach is encouraged. So the take-home points are dynamic parameters such as SPV and PPV can help guide fluid management. In patients who require significant amount of fluids, balanced crystalloid is the solution. Neither a restrictive nor a liberal fluid therapy has shown to improve outcomes, but a hemodynamic-driven GDT may lead to improvement in perioperative outcomes. Fluid overload can lead to increased morbidity and thus should be addressed in the postoperative period. These are my references. Thank you.
Thank you, Dr. Bhuvana, for making again this very complex topic simple. And of course, Dr. Devatiyas is there with us to take us throw more light on this subject, because I think he's one of the most experienced anesthesiologist, perioperative physician and intensivist who has done a lot of research in this area. Dr. Devatiyas, would you like to add anything or like to specify as a take-home message from this talk, sir?
Yeah, so I think we must congratulate Dr. Bhavna for that very elaborate presentation. She's covered almost all the relevant tests and methods of determining fluid responsiveness and which fluid to give and so on. So I think one aspect is giving fluids during surgery in the OR, and the second is giving later post-op in the ICU. And many of the, for example, the pulse pressure variation is very easy to do in the OT, because invariably by and large, we don't give very low tidal volumes. I mean, 8 ml per kilo is often given in intraop, although some people are still giving less, about 6 ml per kilo. But by and large, 8 ml per kilo is generally acceptable for surgery. So the pulse pressure variation becomes very useful and very easy, because you don't need a cardiac output monitor. All you need is an arterial line. And today we also will or have and soon will be available freely a non-invasive continuous cardiac output and non-invasive blood pressure monitoring, which will allow you to do all these parameters non-invasive with a cuff on a finger. So, so this will also make things easier. And maybe right now only in patients who have an arterial line we can do these, but if we have this technology and we invest in it, then we will be able to do this even in patients who do not have an arterial line. That's going to be an important step forward. Also, this concept of liberal and restrictive, these numbers are not very good. Of course, everyone says you must give optimum, but the real problem is how to find out or define or decide
optimum.
what. So, but if you use the pulse pressure variation if you, let's say you're doing surgery where you want to give restrictive, you want to give less fluid, you can set a higher cutoff for pulse pressure variation. So instead of giving when the pulse pressure is about 13 to 14, you give fluid with the pulse pressure hits say 16 to 18 or something like that. So you can uh, vary the cutoff to decide when you want to give fluid. And at the end of the day, we must uh, decide whether the fluid you've given is enough by looking at some of the downstream parameters. So like maybe the urine output is a simple one, but not very good in the perioperative period because of the stress response and the hormone secretion and so on. But the lactate levels, the central venous oxygen saturation, the mentation of the patient, maybe if you're doing brain oximetry, then cerebral oximetry or tissue oximetry or something like that. I think that should be the key. So I think it's okay to start off as a number that we will give XML per kilo per hour, but ultimately we have to titrate based on the patient's response and the patient's need and that sort of thing, and not be married to any one particular philosophy of fluid therapy. The only philosophy we should be married to is the patient should do well, and of course, the least possible intervention or the minimum in sort of things that we can do.
Kiran, you wanted to ask something?
The current era, how to assess fluid response patient with reduced EF undergoing esophagectomy plus gastric pull-up. Fluid
So
responsiveness in a
you
patient
know,
with reduced ejection fraction who is undergoing esophagectomy plus gastric pull-up.
so who have you asked this question to?
This question is for you, sir. Actually, how
For
do
me.
you assess fluid
I was
responsiveness?
hoping it was not for me.
Okay.
Okay, so all these tests, this pulse pressure variation and all these tests which rely on heart-lung interaction, there are 2 or 3 caveats that they work. One is when both ventricles are functioning normally. Okay, so and secondly, when there is normal sinus rhythm. So if either of the ventricles is not functioning normally, then you cannot use these tests of fluid responsiveness. So you cannot use PPV with left ventricular ejection fraction with heart failure. In heart failure, paradoxically, what can happen is that you will get a high PPV, but that is because excess blood in congestive heart failure is being squeezed out into the pulmonary circulation. And if you give fluid, you'll actually make the heart failure worse. So in this setting that you talked of a low ejection fraction, 20%, I think it might be dangerous to use PPV solely to guide fluid response. Similarly, if you've got right heart failure or right heart dysfunction, again, these values are not very good. Okay? You should not use them. Secondly, if you're doing an open thoracotomy, the PPV cutoff values may be much less because there's not much fluid pressure being transmitted when the chest is open. If you're doing laparoscopic, they seem to work, but again, with the intra-abdominal pressure coming in, you might have to just be a little careful before you blindly interpret the results. So if you're doing a esophagectomy in someone who got a 20% ejection fraction, I think I would initially start off with a conservative sort of fluid therapy.
Vasopressor
And
prophylactic.
sorry,
Prophylactic low dose vasopressor, you mean to say, along with
yeah, I might want to put a. So again, now echocardiography is not possible in most intra-abdominal operative settings. Similarly, in the case of esophagectomy, a transesophageal echo is also not going to be possible. So you're going to have to rely purely on your clinical senses and what's going on with the patient. So you give fluid, you can put in a cardiac output monitor with an arterial line. So you can use the response of stroke volume. Say you put something like a flow track, measure the cardiac output, and you can use the response of stroke volume to fluid loading as an index of whether to give more fluid or not. Then you can use your stroke, whether the patient is not responding to fluid, but still has a low cardiac output, then maybe you can add some. If the blood pressure is low in that setting, you will need to add a vasopressor like say noradrenaline. Okay. And like some people would start off with a low dose norepinephrine infusion because norepinephrine is not just an alpha vasoconstrictor, it's also got some beta effect. and therefore can act as has some inotropic effect. So it's a reasonably good drug to start with, but then in a patient like this, you have to modify the your therapy depending on the results of your cardiac output monitoring. So the goal-directed therapy that you would advocate in this setting is what we call as stroke volume optimization. So that is give fluid, measure the stroke volume. If the stroke volume doesn't increase by more than 10 to 15%, this patient is not fluid responsive. The downside is you first have to give the fluid and see the response.
Thank you,
Not
sir.
very just to
Hello? Thank you, sir, for such a detailed explanation. I have one more question for you. How do you treat hypotension in a post-operative patient in ICU who is a chronic hypertensive, was on antihypertensives? So right now BP is like 90, 60. Would you prefer NORAD or would you prefer hyperoncotic solutions like albumin to treat hypotension in post-operative patient in surgical ICU?
So,
Devatiyas, sir, this question is for you.
okay, so I think so. Hypovolemia, that there is no bleeding, okay, and there is no myocardial depression. So otherwise, the causes of hypotension need to be evaluated, right? You look to see whether preload is reduced, and that commonly in the post-op setting, it's hypovolemia and or bleeding because leading to hypovolemia. Ischemic heart disease, then maybe you want to do a quick echo to look at his cardiac function, to look at his IVC status, to look at his assess his volume status. So assuming all that is okay, and you believe that this is because of so he might need a bit of fluid, he might need a bit of a touch of vasopressor, and if he's depending on what antihypertensive he's been receiving, so if he's been on a ARB or he's been on a ACE inhibitor, then some of them may have prolonged effects and have a little reduced response to noradrenaline and so on. So based on that, you would go. So what was your specific question? Whether you would give noradrenaline?
What do you choose? Like, what do you prefer to treat hypotension, noradrenaline versus albumin? Because we see like capillary leakage, hypoalbuminemia in post-operative patients. So still, if you give fluid, because of the capillary leakage, the patient will be having persistent hypotension. Because of the relative hypovolemia, the patient will be in hypotension. What do you prefer, like albumin versus noradrenaline, to maintain adequate map for this particular patient?
Again, it will depend on what your monitoring tells you. If you feel the patient is hypovolemic, he should certainly get fluid. And maybe he can get a crystalloid, maybe he can get, and then you also look at your cardiac function. And then you can think of adding noradrenaline. But I think it is very crucial in the immediate post-op period to exclude hypovolemia, to exclude bleeding, post-operative hemorrhage as a source of your hypotension. And once you've sorted out that bit, then you can, and the fact that how good your heart is, then you can give some fluid. And then after you've given us some amount of fluid, which if that is indicated by your monitoring, then you get a touch of noradrenaline. But I think blindly giving either albumin or blindly giving either noradrenaline is probably not the right way. If the BP is seriously low, now if say for a patient who's normally thought out what the of hypotension in many of these patients, especially if say the patient also having an epidural, if the patient's also being made to sit, and so just take care of all these simple things first.
Thank you, sir. Last question. Is there any role of albumin in surgical ICU patients?
So
apart from the
albumin is,
hypotension, hypovolemia, is there any role of albumin? Is there any cutoff which you have, like to administer albumin or to prescribe albumin in post-operative patients?
So I don't know. I mean, there is always patients. So I don't think it is the universal or the go-to agent to treat hypovolemia if you want to give fluid. If you've given a lot of crystalloid, if the patient is, say, having liver disease, especially, or the patient is having a low albumin, very low albumin to start with, then of course you can consider albumin. But as the starting point, it would be a crystalloid. And then depending on other conditions, you can decide whether to give albumin. Give volume, then of course you'll give 4 or 5% albumin. And if the patient has had ascitic loss, if the patient has a lot of pleural fluid being removed, yes, you could certainly consider some albumin. But otherwise, the default starting point would be a crystalloid.
Thank you, sir. Move on to the next topic. Impact of perioperative nutrition on microbiome and patient outcomes by Dr. Lakshmi Elavarthi. She is American board certified anesthetist, and she did her fellowship in cardiac anesthesia from Cleveland Clinic. She is a clinical head at AIG Hospitals and anesthesia department. Over to Dr. Lakshmi Elavarthi.
He also is a certified transinsular echocardiographer, and routinely we do TE for non-cardiac surgeries at our place. Thank you, Dr. Lakshmi.
So hope you all are having an enlightening learning experience. The last but not the least topic of impact of intensive care unit nutrition on the microbiome and patient outcomes. And perioperative nutrition therapy is always a very important and vital topic of the patient care, but yet often overlooked by the surgical aspect of the surgical care, just like how it became the last topic of today's webinar on a lighter note. So significant disparity exists between the evidence-based recommendations and the practices that's being followed by the traditional surgical training. So the perioperative care, it encompasses the pre-op, intra-op, and post-op. The preoperative nutrition status, the management and the optimization starts right from the PAC clinic. It includes assessment and intervention. And the assessment includes the past medical history, which includes the chronic infections and also chronic medications list that the patient has been on, and also the physical examination that includes the height, weight, and BMI, and other vital signs, and also the nutritional, any signs and symptoms of nutritional deficiency, and any prior surgical history. So assessment is nothing but you're trying to find the patients that are at risk and who would benefit from supplementation of nutrition before the surgery. And mainly in our AIG anesthesia department PAC clinic, we use two tools, which is GLIM criteria and NRS 2002 score. But slowly we are moving towards GLIM criteria nowadays. GLIM criteria is nothing but a global leadership initiative on malnutrition, which includes phenotypical criteria and etiological criteria. Phenotypical criteria, we are looking at weight loss, low BMI, and reduced muscle mass. And the etiological criteria, we are looking at reduced food intake or absorption, any recent weight loss or gain, and increased inflammation, any signs of infection or sepsis. And the NRS 2002 score criteria, it includes the sum of nutrition score and also the age adjustment score and the disease severity score. So this is our AIG anesthesia PAC clinic, where we often look into for each and every patient in order to individualize the nutritional assessment and the optimization. We do NRS 2002 score and also GLIM criteria. Coming to nutritional intervention part of it, whenever we identify the patients at risk for malnutrition, then we subject all those patients to new regime prehabilitation program, which is mandatory at our PAC clinic, where N stands for nutrition, E stands for, and W stands for worry or stress reduction. We always believe in multidisciplinary to assess the endurance. We always involve the hand dynamometer, which we use in our PAC clinic, which is a hand grip strength. We take 3 measurements and average of it, which we use to find out the muscle strength of the patient. And there is currently a study going on in our department where we are trying to see if this hand dynamometer can be a surrogate marker for in replacement of a pulmonary function test, PFTs. And the physiotherapist is also involved wherever we feel like the patients need to build up their endurance and the muscle strength. And the worry and stress reduction, if at all it's needed, and appropriate therapy strategies to include them, we involve a clinical psychologist at the AIG hospitals. So coming to our nutrition, which plays a major part of the nutritional intervention. Usually when the patients are subjected to the surgery, the surgical stress, it increases the post-op insulin resistance, and also it does immune suppress the patients, and it also increases the uncomfortability of the patient perioperatively because of the fasting. So when we do supplement the nutrition, usually we do, wherever it is required, the carbohydrate loading of a rich carbohydrate drink 3 hours prior to the scheduling of the surgery. It's shown to be, there is currently a study going on this too at our department. It has shown to, so far the results have shown to attenuate the adverse effects of peri-op fasting, especially in the diabetic patients. So the nutrition supplementation after dietary counseling, we choose for enteral nutrition or parenteral nutrition, which are self-explanatory. And when we chose for enteral nutrition, either it's in ideal scenarios, it's oral supplementation. And the oral supplementation includes micro or macronutrients, and also pre, pro, and synbiotics, which will go in detail in the later topic. And also the recent new aspect of this nutrition is immunonutrition, which include nucleotides and also omega-3 fatty acids, which actually help in increasing the immunity, decreasing the stress, and also increasing the protein synthesis. Wherever the oral supplementation is not feasible, we opt for tube feeding, either it's gastric or post-pyloric. And whenever there is a contraindication for EN, which is enteral nutrition, in scenarios of intestinal obstruction or severe shock and sepsis where the patient has been on high doses of vasopressors, we generally opt for parenteral nutrition, which is through the intravenous. And when you compare enteral nutrition and parenteral nutrition, there have been so many studies, and most important ones are the calorie study and also Nutriria study. Both of them showed that there is no significant when you compare between enteral or parenteral route. Support wherever is feasible is recommended over parenteral because of its relative simplicity, safety, reduced complications, and lower cost. So coming to the intra-op part, continuing whether to continue the nutrition intraoperatively or not, it's still a challenging arena, and many studies have been happening, but not to a conclusive thing is happening. So, but there is one study that caught my eye. It's was studied in critically ill burn patients, and as you all know, burns is like a hypermetabolic state. And they studied and evaluated the safety and efficacy of intraoperative enteral nutrition. And this is a systematic review and a meta-analysis which showed, and when they tried to continue in intubated patients, and they continued the feeds intraoperatively also, there's no statistically significant increases in the risk of mortality, wound infections, pneumonia, and aspiration in patients receiving intraoperative enteral nutrition. But when you look at those individually, within those individual studies, the patients who received intraoperative nutrition compared to perioperative who followed the standard protocol of perioperative fasting, they received more calorie intake. So coming to intensive care unit nutrition, which is the main topic of today's webinar. So the research that's going through the perioperative ICU nutrition studies showed some recommendations which we strongly follow at AIG Surgical ICU department. And we'll go through what do we know one should not, and what do we think one should do, because we all believe in no harm approach to the patient care, and the effect of nutrition and microbiome and patient outcomes, which is a recent research topic that's going on and actively being looked into. And finally, what do we still need to find out to individualize the nutritional outcome on the patient care? So before going into the recommendations, let's look into the summary of the recent trials that's based on. In the most recent RCT, patients receiving 6 versus 25 kilocalories per kilo per day by any route early on achieved readiness for ICU discharge and had fewer GI complications. When it comes to the critical care patients, high protein delivery, obviously it provides better muscle volume maintenance, but only when the patients are being subjected to active early rehabilitation. But when it comes to the patients that are bedbound for whatever the reason, whether hemodynamic instability or for the surgical reasons, and they have a baseline AKI and acute kidney injury and more severe illness, these high protein dosage is proven to be harmful in those patients. And another prospective observational study suggested that early full feeding, especially enteral, is compared to delayed feeding, is associated with higher 28-day mortality. And the protein study has been an effort protein trial that showed that the high protein dosage early on is harmful to the patients, especially in critical ill patients. And there have been many studies not accepting this Nutriria, Target, and Arabi, and also Epenic. All these studies, they looked into early full energy versus permissive underfeeding, trophic feeding, or start low with daily progression with a daily evaluation of the patient caloric needs and the feeding tolerance levels, shown to be in increased mortality, more infections, and also more GI complications. Or in some studies, they showed that it's equivocal, not affecting much of a difference in any of the outcomes, but associated with more of GI complications wherever the early full energy delivery has been implemented. So after these studies, then we translated these evidences into our practices, and which became the ESPEN guidelines criteria also. So we shouldn't, what are the things that we should avoid? We should avoid early full feeding by any route, and also avoid high protein in the early period. And we should monitor for refeeding, overfeeding, and any of the GI complications. And what we follow is we start early enteral feed, nutrition with low dosage, and we increase it progressively. And we also individualize it after 3 to 5 days of ICU admission based on the illness trajectory, based on how the illness is progressing. So what we are unsure still, even after these lot of trials that's been happening and the research has been progressing, is that what is the actual optimal time point to start? Are there any biomarkers for it? And what is the slope of progression, and how to individualize it to each and every patient based on the whole clinical scenario of the patient is going through? And what is the treatment of effort feeding intolerance, which will go in detail later on in our presentation. So at AIG, I would like to briefly take you all into what our actual practice is at AIG Surgical ICU. And we do not provide full, which is 70 to 100% energy target in the first few days of admission. And we do not provide high dose protein in the first few days of admission. And we do start nutrition within first few days of admission, which is low dose EN. And wherever, as we previously discussed, whenever there is a contraindication for EN, then we start with a low dose parenteral nutrition. And at a day of 3 or after, we use indirect calorimetry in order to reduce the risk of overfeeding. And we do monitor for GI dysfunction to avoid or to identify any severe complications of enteral nutrition. And whenever there is an enteral feeding intolerance, there are usually 3 options: either we just observe, or to use prokinetics, or whether to go for post-pyloric feeding. But at our surgical ICU, we'll try not to aggressively treat it, just to maximize the amount on the whole clinical scenario of the patient and their clinical progression. We do decide on not treating the enteral feed intolerance very aggressively. And we do monitor the metabolic response, especially the insulin requirements for feeding, and we progress it very slowly, both calorie and protein concomitantly, independent of whichever the route we follow. We avoid prolonged underfeeding with individualization of nutrition targets from day 3 to 5 after ICU admission. And daily clinical evaluation happens both from a dietitian and also intense, so that we try to estimate the point of transition from acute to recovery phase, which is very important, because this is based on only the clinical experience and the clinical scenario, because there are no precise markers exist that will define the point of transition from acute to recovery phase. And we do monitor, most importantly, for refeeding syndrome. So I'll just pause here for a couple minutes just to go through, take you guys in detail for what is refeeding syndrome and why is it so important in ICU, and where does the journey of refeeding syndrome starts. Refeeding syndrome is nothing but it's includes a potential fatal shifts of fluids and electrolytes, and it's due to hormonal and metabolic changes that occurs in malnourished patients mostly who receives artificial refeeding. The incidence of refeeding syndrome in perioperative patients is truly unknown, but whenever you look into those biochemical markers and you notice low phosphorus, hypophosphatemia, then the incidence is known to be 0.4%. And the hallmark of biochemical feature is the hypophosphatemia, which also accompanies abnormal sodium and fluid balances and changes in glucose, protein, and fat metabolism. Thiamine deficiency is very important, and hypokalemia and hypomagnesium. So what is the National Institute of Nutrition criteria in order to identify the patients who are at high risk? So whenever there is low BMI and unintentional weight loss and little or no nutritional intake for more days or for more than 10 days, and low levels of bivalents and the potassium before feeding. So if it's severe enough, then it's one or more criteria is enough to keep those patients at risk in the criteria of getting exposed to the refeeding syndrome. But if it's to the moderate level, then 2 of these criteria has to be met. Then we put them at risk. We include into the group of patients that being at risk for refeeding syndrome. And also the history of alcohol or any drugs, including insulin, chemotherapy, antacids, diuretics, which affects the electrolyte and the fluid balance, also has to be, you have to keep an eye on those patients also, so that you can avoid and treat them appropriately if at all they fell into that region of refeeding syndrome. And when you are doing the PAC, you need to keep an eye on all these patients, all the post-operative patients and elderly patients, oncology patients, and the patients with chronic malnutrition and electrolyte depletion, chronic alcoholism, and patients who are using long-term uses of diuretics and antacids are also has to be closely observed. So if at all it happens, after going all the protocol, identifying them, trying to assess them and trying to manage them, and even then if the refeeding syndrome happens in the ICU, when we identify that the patients are at a higher risk of refeeding syndrome, then prophylactically we administer them thiamine, high potency vitamin D supplementations along with other multivitamins. And we start feeding, and when we start it very slowly and we increase it progressively based on their tolerance levels. And we do rehydrate them carefully, and we supplement as per the biochemical markers, all the potassium, phosphate, calcium, and magnesium. And we do closely monitor them for the first 2 weeks and then modify the treatments as appropriate. So the stepwise approach for initiation of medical nutrition that we follow at AIG's SICU department is upon ICU admission for every patient, we establish a nutrition plan by involving a dietitian. And we decide the route of the therapy, whether it's going to be oral or enteral or parenteral, depending on the clinical scenario and the surgical procedure that they have been put through. And also the timing of the initiation, that plan includes within usually 48 hours of admission. And also depends on the hemodynamic stability of the patient, and if they are unstable, whether they are on vasopressors and what's the dose of the vasopressors. And we establish their caloric needs. We measure the resting energy expenditure via indirect calorimetry. But the downside of indirect calorimetry is we cannot apply this for unstable patients. That's the problem that we have with this. And also we establish the protein requirements also. So day 0 to 2, we do initiate, as we said, within 48 hours of the admission, we all initiate the nutrition, whichever the route is feasible for that particular patient in our ICU. And we do provide 70% of measured or the estimated needs, and more accurate measurement, that is usually 10 to 20 kilocalories per kilo. And we do provide 1.2 to 2 grams per kilo protein, Because in all these critically ill patients, as per the effort protein trial, when you are providing them more than 2 grams per kilo, then it's doing more harm to the patient than doing any good. And we also measure the intake for every 24-hour period. And in ICU day 3, we reassess the intake and we try to progress as long as there is a good tolerance to the feeding by any route. And suppose if it's greater than 60% of the needs are being met, then we increase it slowly to 60 to 100%. But suppose only less than 60% of the needs are being met, then we supplement it with parenteral nutrition so that we take it in the right direction of achieving 100% of the target needs. And we do continue the protein goals of 1.22 grams per kilo. And we, as we initially mentioned, we do continue our daily measurements or intake. And day 4, usually in the ideal scenario, the target is to achieve 100% of the target needs, regardless of the route that we use. And we assess the nutrition delivered again, and we try to continue the same protein requirements. And if supplemental on day 3, we decided to supplement the nutrition with parenteral nutrition, then on day 4, we try to increase the parenteral nutrition so that the 100% target needs are being met. So this is mainly for on ICU admission. But when we take care of these daycare surgical procedures where GI system is not involved to a greater extent, so the ideal protocol that we do follow in our department is we advance the diet as the patient tolerates. That depends on amount of the narcotics or the pain medications that's needed, and the type of surgical procedure and the patient's history if they are prone for more nausea or vomiting. So basically in the non-GI procedures, what we are looking at is whether they're prone to nausea or vomiting, whether the nausea and vomiting is reasonably controlled, the pain is reasonably controlled, then we advance the diet as patient tolerates. We don't necessarily follow a strict rule of 2 hours, a certain period duration of NBM fasting post-operatively in those kind of patients. Only upon the ICU admission, once they cross the transit area, and they get admitted to the ICU, and where the GI system and oncology cases where the GI system is mainly involved, that's when we do follow this medical nutritional therapy. And most of the patients, that's where they need the MNT other than the oral route. And all our SICU surgical staff are all trained on how to proceed the dietary needs as the patient tolerates. So coming to protocols based on the trials, evidence-based recommendations, that is early enteral nutrition, and if needed, combined with parenteral and moderate calories and following low dose of protein. And also right from the PAC, if needed, supplementing them with symbiotics, probiotics or prebiotics, and increasing the beneficial taxa like Clostridium, Lactobacillus and Bifidobacteria, who are the short chain fatty acid producers. Will go in detail in later on about this microbiome species. So there are actually a lot of studies that when follow this protocol, that the patient outcome has been very significantly favorable, and decreasing the hospital stay and overall patient satisfaction has been increased. Whereas the malnutrition, delayed nutrition, inadequate protein and excess calories early on, and whatever, whether the surgical procedures or other drugs that decrease the microbial diversity and increasing other opportunistic taxa like Enterococcus, Proteobacteria, then there is a negative outcome on the patient care. So what is actually the gut microbiome? So Dr. Jeffrey Gordon, he is considered as the father of gut microbiome nowadays, and he has been doing an excellent work in Washington University. The microbiome is nothing but it's a complex group of microorganisms comprising mainly of bacteria, but also fungi and viruses that reside along the GI tract. What does it actually do? Why is it so important to us? It mediates host immune responses, and those responses can be signaling the immune cells when needed, promoting differentiation of T cell subsets, and stimulating immunoglobulin A. It also protects against other enteric pathogens And it also secretes, helps with the secretion of antimicrobial peptides and fermentation of dietary fibers into short chain fatty acids. These dietary fibers are nothing but the probiotics that we were talking about, supplementing them right from the beginning in the PAC clinic. So these short chain fatty acids, what does they actually do? They serve as a fuel for colonocytes and also as immunoregulatory signaling molecules. Just like through, and also they modulate the neurological processes through gut-brain axis. And they produce antioxidants, and also they regulate the insulin sensitivity, because the surgical stress itself increases the insulin resistance post-operatively. So whenever any sort of disturbance happens in the intestinal ecosystem, that decreases the diversity, the microbial diversity, and also increases certain taxa that's harmful to the patient, then these homeostatic processes that's been maintained by the microbiome are attenuated. Such scenario is called microbial dysbiosis. So what does this tell us? That microbiome in the recent research areas, it's being considered as a functional organ. So why are we talking about this microbial dysbiosis in the perioperative nutrition area? Because most of our patients perioperatively are getting exposed to antimicrobials at one point of their hospitalization. And the more concerning thing is, even after 180 days of administration of these antimicrobials, certain taxa are being reconstituted. And the other thing, second most, is the 4-hour exposure to either 100% oxygen or a combination of volatile anesthetic and 100% oxygen is increasing the, actually it's decreasing the beneficial commensals that actually help us in producing the short chain fatty acids, especially the Clostridium species. And the proton pump inhibitors, which if at all the patients are getting exposed continuously for 4 weeks, then that is increasing the taxa of Enterococcus and also Streptococcus. And this getting exposure to opioids for 24 hours is still in the preclinical models, but it has shown to be increasing the infections to Enterococcus faecalis, and also it increasing the virulence of Pseudomonas aeruginosa. So as Dr. Trupti informed us previously, that we try to follow whenever we identify these patients who are at risk for this, we try to follow the opioid stewardship policy in these kind of patients to avoid this, since there are other alternatives available other than the opioids for the pain management. And last but not the least, even in the patients with severe sepsis and shock, where there is decreased intestinal perfusion, so it's shown to increase the mucosal inflammation, thereby impairing the barrier defenses. That is also shown to alter the microbial, the gut microbiome, which is leading to microbial dysbiosis. So as you see, most of them are related to our perioperative period mechanisms in one way or the other. So how does this affect the clinical outcome? As we are trying to implement all our policies and the protocols and our clinical practices based on the clinical recommendations, based on the trials. So we again went through a lot of studies that clearly shows us that how it's going to affect our clinical outcome and how it affects our patient. There is a large scale study by Prescott and colleagues. Nearly 11,000 patients were involved. And all these 11,000 patients were divided into 3 hospitalization types: non-infection, infection, and CDI, which is difficile related. And it's shown to be after discharge, they were associated with increasing risk of sepsis, say like 4%, 7%, and 11% respectively. Although this is an associative study, but it still supports the idea that microbial dysbiosis, it impairs host defense mechanisms and increases susceptibility to infection. And the studies which uses the high throughput sequencing techniques, genomic techniques, that showed that even enteric bacterial translocation is likely a major contributor to the microbial dysbiosis. And another landmark study of patients who are undergoing hematopoietic stem cell transplantation, they revealed that whenever there is a perioperative intestinal domination by Enterococcus, those patients were associated with 9-fold increased risk of developing PRE and domination by proteobacteria were associated with a 5-fold increase of gram-negative rod bacteremia. Microbial dysbiosis not only affecting the patients for increased susceptibility to infections, it also affects the post-term outcomes like anastomotic insufficiency and peritonitis after major intraabdominal surgeries. So the research still that's going on, that's showing, trying to prove the effect of nutrition on microbiome is still in its infancy stage. The nutrition, especially the indigestible carbohydrates, they interact directly with the microbiome and they either inhibit or help them with the growth of the microbiome. So diet is one of the greatest environmental determinants of microbial composition and gene expression. So as you see here, so the diet, it affects either in the dietary intake in any form, in any route. It affects the host gene expression, which impacts the metabolism, and it also shapes the microbiome community. Either it's host-derived dietary metabolites or the products of host and microbial digestion, they reach the gut lumen, which in turn impacts the host health and disease process. Soluble fibers and prebiotics, the emerging evidence shows that the soluble fibers or the prebiotics are extremely useful in certain selective patients so far. So what does this prebiotics means? They're nothing but a non-viable substrate that promoted growth of beneficial, so nothing but a soluble fibers. Any dietary substrate that has some fiber content is considered as a prebiotic. And when these fibers are used, especially the plant polysaccharides, the aim is often to enhance the growth of short-chain fatty acid producing bacteria. And as we discussed, these short-chain fatty acids, they act as a fuel to colonocytes, and also they help you with immunoregulatory signaling molecules. And also again, as we are all, the clinical practice has been based on the studies, it shows that who received higher quantities of fiber, they're associated with higher SCFA levels, and also the SCFA increased producers, and thereby significantly less enterococcus. And the probiotics or the live microorganisms that confer health benefits, and symbiotics are nothing but a mixture of probiotics with prebiotics. So in the largest meta-analysis that evaluating the administration of these pre or symbiotics in nearly 3,000 critically ill patients, a clear benefit was shown in the reduction of infectious complications, reduction in VAP, and in duration of antibiotics use. So why can't we use this supplementation for all the patients that we are subjecting them to surgical stress? Here, the generalizability is challenged by the small sample size of the studies that we have available so far, and variable therapy formulations. There is no standard therapy formulation that has been designed so far, and the treatment lengths. And also a few reports of bacteremia and sepsis are associated with these biotic supplementations. This is what restricting us in generalizing this to every patient. But in few, in our AIG hospitals, we, depending on the patient and getting the patient subjected to a particular surgery, then we are individualizing the treatment regimen for those patients. Last but not the least, when it comes to the microbiome supplementation, is the fecal microbial transplant, which we proudly say that being done at AIG. And the primary treatment strategy for refractory and relapse. But this is the most promising therapeutic option that's available out there so far. But again, it's the least well studied. And compared to pro, pre, and symbiotic supplementation. And the clinical benefit has also been shown in irritable bowel diseases and irritable bowel syndrome, intestinal cancer, and also mainly in ICU-associated dysbiosis. Since it's the least well studied, again, it has to be, you have to look at the holistic approach before you apply it to any patient, before you suggest it, recommend it to any patient. So far, we focused on what we are doing and what we are trying to avoid to do no harm to the patient. So what do we still need to find out in this arena of perioperative nutrition? So we're looking at three perspectives and their own challenges in order to optimize the perioperative nutrition in critically ill patients. It's dietitian, basic scientist, and the intensivist. The dietitian, we usually involve them whenever we assess the patients and find out that they're at risk. Then the dietitian comes up with a plan of the assessment is being done by dietitian too, in addition to the anesthetist, and an individual approach has been planned, and also monitors the effect of overfeeding and underfeeding for these kind of patients. What is the arena that we still need to find out in order to optimize from dietitian perspective here is to define the strategies to know what is the transition point from acute to recovery phase. When do we find the transition point? Because as of now, we are only looking into the transition point based on the clinical scenarios and overall how the patient has been doing, but we don't have any precise markers as in such to decide what is the transition point. So we believe that is the area that we still need to look at in order to optimize the nutrition aspect. And when it comes to the intensivist, so the intensivist implements and decides the route and the timing and the dosage, and following the ESPEN guidelines as we do at surgical ICU. And the intensivist also monitors the complications of overfeeding or underfeeding or metabolic derangements and try to optimize the patient outcome. So the area that it still needs to be researched more from the intensivist perspective is that trying to find out what is the exact timing and the dosage that we need to follow. And what is that full, because we have been talking about early full enteral nutrition is harmful to the patient. What is that full nutrition definition means? What we are thinking is the full nutrition is actually what it is, or we are misinterpreting it as a full nutrition. So the actual definition of full nutrition. And when we are trying to overfeed or provide high calories to critically ill patients, why is it associated with a negative outcome of the patient? So what is the real basic mechanism that is involved, when we are providing those kind of an approach, nutritional approach to the patient, is what needs to be done from the intensivist perspective and also from the basic scientist perspective. And the other thing is the enteral feeding intolerance. So as we initially discussed, there are three, whenever there is an enteral feeding intolerance happens in a patient, three approaches needs to be followed, whether we still observe or we try to introduce prokinetics or we try to do post-pyloric feeding approach. So what is exactly that needs to be done rather than just trying to figure out and play the game on how the patient responds to either of these. And as I said, from the basic scientist perspective also, that basic mechanisms has to be dealt out, and there is no specific tool that determines the nutritional need of it. And whenever you implement nutrition, it has to be early and it has to be slowly and progressed. And within 48 hours of admission, the nutrition has to be started. And it has to be moderate calories and low protein, especially when you're dealing with the critically ill patients with baseline AKI. And also, whenever the patients are with shock, then you prefer a early nutrition rather than delayed, especially only when the patient pressure support is low. If the patient is dependent on a lot of pressures, then you chose the parenteral nutrition. And coming to microbiome, the soluble fibers, pro and symbiotics, they may improve outcomes in critical ill patients after intra-abdominal procedures, but has to be selective. And as we know, the alterations mechanisms, whatever is contributing to microbial dysbiosis has to be minimized if at all it can be. And clinicians has to be thoughtful, especially the anesthetist, when they're providing antimicrobials, exposing them to 100% oxygen for a longer period of time. And for GI physicians who are putting the patients on PPIs for longer period of time. So it has to be thoughtful before we are prescribing to the patients so that it doesn't result in microbial dysbiosis and impair the host defenses. So last but not the least is the microbiome has a potential, significant potential as a therapeutic agent. But again, as we said, there's a lot of studies has to be executed in order to properly implement it and use it as a marker. So thank you so much for this opportunity, and hope all you are having a good time and have a good evening.
Thank you, Dr. Lakshmi, for emphasizing. In fact, it was a good learning for us about microbiome and as a functional organ. Dr. Devatiyas. We are fortunate again that Dr. Devatiyas is there amongst us. And I must acknowledge that he has done a lot of work on nutrition in especially post-surgical oncology patient. And also he has been a part of task force guidelines about Indian parental enteral nutrition. So Dr. Devatiyas, are you around, sir? Yeah, sir is there. Would you like to add anything, sir, about post-surgical nutrition deficits and when to start, or certain blinds that we have, if we can throw more light? I think so. Anyways, I think he may join, or probably I think it was getting to going beyond the scheduled time. But nevertheless, it was a very fantastic presentation from all four colleagues of mine who have done an excellent job. I think we must acknowledge them, and we must credit each one of you. And my special thanks to Dr. Devatiyas for moderating this session, and my colleague Dr. Kiran for giving his valuable insight. Again, I may be failing in my duty if I don't acknowledge the IT team led by Mr. Mohan and the Department of Academics, Mr. Satrayana, and of course our beloved Director of Surgical Gastro and Director of AIG Hospital, Dr. G.V. Rao, and the Chairman, Dr. Nageshwari, for giving us this podium for our webinar and education activity. Thank you very much. And any questions, if you have any from today's webinar, you can always post it to me, or in the chat box, or you can, any of our mails ID you have, and we'll be pleased to answer them if we are aware about it. Otherwise, we'll read and throw the questions. I mean, answers on the issues which you have. Thank you very much. We sign off for the day and have a great evening.